One question, you spoke to this in the terms of combining or spreading risk across different pools. What can you say about the effect of uninsured or underinsured individuals that can't be denied care and probably are not going to pay for their care on the, I don't know, everyone knows what the effect on total cost is. In healthcare, like every other business, you have a small percentage of people driving a large percentage of the costs. In some cases, those people are paid for by government programs or whatever, but uninsured or underinsured individuals, do you know much about like how much of that is taking place and what that we could weigh in on the total cost of going to a hospital?
So, I mean, let's talk about the Medicare, Medicaid. I can talk about payer mix, right? As a hospital manager, one of the metrics that we look at and we pull is the payer mix. That would be either private insured, self-insured, self-pay, or CMS or Medicare, Medicaid.
Yep.
And so, not to get into the percentages, but as a healthcare organization, we're looking for a high population of our patients to be private insured or self-pay, because those are the highest reimbursed. Those patients will reimburse the hospital at a higher amount. The Medicare and Medicaid, it's a percentage. Once we hit a certain percentage, the lump sum or the stipend that the government gives for those, whether it's state or federal government gives for those services that we offer, we're taking a cut. Now, I can't say it's 50%, and it would vary per procedure, would vary per department. So, getting into the specifics doesn't really make sense. But it's critical to keep that payer mix favoring the private insurers to keep the revenue coming in.
Is there anything that you actively do to try to improve the balance of payers, to, as you said, to more private and self-pay?
Well, no, because then there lies the ethics.
Yeah.
As patients requests come in, right? We're a procedure-based area, so as a physician refers a patient for a procedure in our department, we don't vet. Okay, let's look at their insurance before we schedule them. They come in and we schedule them as needed.
Yep.
Now, as we fill the daily schedules, we project out 2 or 3 months, maybe more, 3 or 4 months, and we try to limit, each month to a certain number. So Medicare, Medicaid might get pushed, but there's no guarantee. It's a process where we're always looking to improve, always looking to change. But no, we're not restricting people's care based on their insurance.
Yeah.
Just like you said earlier with the emergency room, someone walks through those doors, they're going to be seen. Are they going to be treated with what they think they need? That's dependent on the providers. But if someone's coming through our doors, they're going to be treated.